Oh, it really is. So, how about you? Oh, yeah, yeah. Yep. We have a good day.
Yes. Okay. What's your name? I talked to you over the weekend. Yes, that's why. Let me. Did you get those links that I sent you?
Yeah.
Okay. You get them normally every day now. We have class. Down. Good to go. Great, thank you. Let's go ahead. Okay, everybody should see the slide that says antidiuretic hormone. That's probably not where I want to be, but let's get down. We were a little further along here. I think this is the last slide. Yeah, I think this is the last slide we looked at from the other day. And I think everybody should see this. The slide that's up now says other thyroid hormones, calcitonin. So everybody should be able to see that. If you can't see that, let me know. And I'm gonna expand the screen and see where we go from here. Okay, we've been talking about the thyroid gland. And we talked about all the things that can go wrong with it the other day, and we finished up with thyroid cancer. And of course, thyroid cancer, like any other cancer, can spread throughout the body. But fortunately, thyroid cancers, if caught, are usually caught early and can be treated. They have a pretty good success rate. Of course, we don't want to ignore any cancer. Now, other things that the thyroid gland does for us. We know it makes thyroid hormone. That's the big one. It controls our metabolic rate. The other hormone that it produces is calcitonin. Now, the parafollicular cells, remember the parafollicular cells? We go back, we can see it here. The parafollicular cells are these cells here. Now, this is a follicle. This is a round follicle. These are the follicle cells that surround it. The follicle cells produce the thyroglobulin and combine that with the iodine to make thyroid hormone, which gets stored as colloid in those follicles. Now, at the edges of these different follicles are the parafollicular cells. The parafollicular cells make the hormone calcitonin. And that section over here, sort of like in the corners, if you will, are where the parafollicular cells are located, because the follicle cells are going to be surrounding every one of these follicles. Now, let me go back here. Calcitonin is the antagonist to parathyroid hormone. Parathyroid hormone will raise blood calcium levels when it gets too low. Calcitonin is supposed to drop blood calcium levels if our calcium levels get too high. we very rarely have high calcium levels. What the what calcitonin is supposed to do is to take excess calcium and create new bone. Calcitonin is supposed to stimulate the uptake of excess calcium and bone growth. So it tends to stimulate osteoblast activity, bone building. It's supposed to inhibit the osteoclast activity. You know, remember, osteoclasts are the bone breakers. They destroy. They're like lysosomes. They dissolve bone and release calcium, and the osteoblasts build bone. You know, they're the bone builders. Well, calcitonin is supposed to stimulate osteoblast activity and inhibit osteoclast. It's supposed to inhibit the breakdown of bone, because if we ever find ourselves in a situation where we have excessive calcium in our blood, that's what calcitonin will do. It will take that extra calcium and put it into our bones. But we don't ever have excess calcium, usually. We shouldn't have excess calcium. It's very rare for us to have excess calcium. It's not impossible, because remember, in A and P, there are very, very few absolutes in A and P. You know, so if I say we never have excess calcium, maybe we could in an unusual circumstance. You know, I once worked with a person whose afternoon habit was to munch her way through a jumbo bottle of fruit-flavored Tums. You know anything about fruit-flavored Tums? They're mostly calcium. You know, they are designed as for treating, you know, short-term relief from acid reflux. She liked eating them, lots of them. We're talking like a jumbo bottle of these things every day, you know, and with the consequences of elevated calcium levels. So in her case, her calcitonin levels were probably pretty high, but the average person is not going to have a lot of calcium in their diet, a lot of excess calcium in their blood. So we generally don't release a lot of calcitonin. You know, there may be occasions where we would, but they're very, very rare. So calcitonin is really sort of like a non-player in maintaining blood calcium levels. The key hormone is going to be parathyroid hormone. Parathyroid hormone, the parathyroid glands, is what's going to give us our keep our calcium levels in our blood calcium levels to where they want to be or where they need to be. But calcitonin has its place. Calcitonin, if our calcium levels ever go up, we've got the calcitonin to bring it back down. Okay, and there's our parathyroid gland. Parathyroid gland sits on the posterior surface of the thyroid gland, usually two glands on each of the lobules. There's four glands, usually four glands altogether. They're about the size, and each one's about the size and shape of a raisin. And they're going to secrete parathyroid hormone. And what they do is they stimulate osteoblast activity to break down bone to release calcium. Because we need calcium for muscle contractions. You know, we have all that calcium in the sarcoplastic reticulum that allows us to contract our skeletal muscles. We need calcium for to release the neurotransmitters at the end of axon terminals. We use calcium instead of sodium for contractions of the heart. Instead of muscle contractions, you know, like skeletal muscle uses sodium and potassium, we have a depolarization, yada, yada, yada. What we have with the heart is we use calcium and potassium. So we have a lot of reason to use calcium, and we can rate our bones to get that. As long as the calcium uptake and the calcium breakdown stay in homeostasis, we're fine. It's when we get out of balance, we run into trouble. Okay, so parathyroid hormone stimulates osteoblast activity, and it also acts on the kidneys and the small intestine. The parathyroid hormone comes from the parathyroid glands. It is the most important regulator of calcium homeostasis. Calcitonin is just sort of watching, because as I said, we very rarely ever have elevated calcium. But if our blood calcium drops, we will release parathyroid hormone. And the parathyroid glands are embedded in the middle of the thyroid. I showed you a slide in lab last week that had, you could see the whole, nearly the whole one of the parathyroid glands surrounded by thyroid gland tissue. And so the parathyroid hormone parathyroid gland is made up of what we call chief cells, and they secrete the parathyroid hormone. Now, what does parathyroid hormone do? Well, I think I said this wrong. I said osteoblast. It stimulates osteoclasts, the bone breaking cells, to digest bone, to release the calcium. So they act like lysosomes, and they simply will dissolve away the bone. It's sort of like one of these, have you ever seen these giant road graders that go along and they're tearing up asphalt, and they're leaving a nice smooth surface behind all the asphalt's being chewed up and thrown into the back of a truck? That's what these osteoclasts do. They slide across the bone and dissolve the bone and release the calcium into the blood. Well, so the first thing they do is stimulate osteoclasts and inhibit osteoblasts. No more bone building right now. We're breaking bone down. The second thing they do is tell our kidneys to retain more calcium. So the first thing is to break down bone. The second thing is to recover more calcium in our kidneys. And the third thing is to absorb more calcium in our gut, in our small intestine. The kidneys activate vitamin D. Now, vitamin D comes from our skin after it's been exposed to ultraviolet radiation. So we produce the inactive form of vitamin D, our kidneys activate it, and then the vitamin D allows us to absorb calcium in our small intestine. So three things: break down bone, recover calcium in our kidneys, and allow more calcium to be absorbed in our small intestine from our diet, thanks to vitamin D. That's what vitamin D does for us. Vitamin D allows us to obtain calcium by acting on the small intestine to say, hey, let's absorb more calcium. That's how vitamin D works. Okay, so, and this, I'm not big on flow charts, but this one is a pretty good one. It shows you the three things that parathyroid hormone does. If our blood levels of calcium are low, we have what's known as hypocalcemia. Parathyroid hormone will stimulate osteoclast activity to dissolve bone. It will tell the kidneys to reabsorb calcium in the kidney tubules. It will then also tell the kidneys to activate the inactive form of vitamin D, which then allows us to absorb calcium in the gut. And so all three of those combined raises our blood calcium levels. So we can use that calcium for other things. We can use that calcium for bone, for muscle contractions. We can use it for nerve impulses. So we have the excess calcium. So our bodies make a distinction that they look at the calcium in our bones as a big storage unit. And so we readily go after that calcium if we need it. Now, conditions with calcium. You can have hyperparathyroidism and hypoparathyroidism. Neither one of them are good. With hyperparathyroidism, you may have a tumor on the parathyroid gland. And what will happen here is that if you are overproducing parathyroid hormone, your bones are going to get weak. You are going to soften. The bones will not be able to support the body. You may see your patient fracturing bones just standing still. You may see the bones bending because they can't support the weight. If we also have, because we're stealing calcium from the bones, we can also raise our blood calcium levels. The mildest problem with that is that we raise our blood calcium levels, we can cause lots of kidney stones. Kidney stones are made from calcium. They're called renal calculi. And so if we have kidney stones, it is a very painful condition. You imagine something the size of a quarter with razor sharp edges trying to be passed through your ureters and your urethra, or it comes from your kidney again and again and again. And this is what happens when we have lots of kidney stones in your patient, caused by the high levels of calcium. And it affects your muscle contractions, and it affects our nervous system. We don't have enough calcium. And you remember how skeletal muscle depends on calcium. Skeletal muscle depends on the calcium to open up the binding sites for the actin and the myosin. Calcium lands on the troponin and causes the troponin to roll out of the way to drag. And when it rolls out of the way, it drags the tropomyosin with it that's blocking the binding sites so the actins and myosins can't get together. And when the binding sites are exposed, we can get a contraction, but only as long as calcium is present. If there's no calcium, the binding sites never get exposed. If there's no calcium in the nervous system, we don't release neurotransmitters to allow an action potential to essentially jump from one neuron to another neuron. So our nervous system isn't going to work. Our bones can break, and our muscles can't contract. So if we have hypoparathyroidism, then our blood calcium levels drop. Usually the hypoparathyroidism occurs if there's been some trauma to the thyroid or the parathyroid gland. If your patient has thyroid cancer and the thyroid's been destroyed or removed, the parathyroid glands usually come with it. And if the patient is not being given some sort of replacement hormone therapy here, they'll likely develop hypoparathyroidism. And without calcium, we end up with muscle contractions that don't let go, or paralysis and death. So there's all sorts of bad things that happen here in either case. Now that's not to say that someone who has thyroid cancer is going to die from hypoparathyroidism. If your patient has thyroid cancer and the thyroid is destroyed to kill the cancer, then they have to go on some sort of hormone replacement therapy for the thyroid hormone and for parathyroid hormone. You've got to have both. So, okay. This is what our bones will look like if our calcium levels are elevated. We're going to be sucking the calcium out of the bones. They're going to get weaker. They're going to get soft, and they're going to fracture very easily. It happens. It happens frequently. Your patient can complain, I was just standing in line and my leg collapsed, or they went to turn a doorknob or unlatch a door, or turn the wheel on the steering wheel, and one of the bones in their arm broke. just snapped because it's so weak. Can't take any stresses. Okay. These are the renal calculi. These are the results of too much calcium. These are kidney stones. You know, the size of look at the size of these kidney stones and their shape. They define them by agony, pain, and misery by the sharp edges. And they can get stuck in the kidney. They can get stuck in the ureter, which drains the kidney. They can be stuck in the bladder. And they're mostly from calcium. And if you've ever had one, or you know anybody that's ever had one, it is excruciatingly painful. So now a person that develops kidney stones doesn't necessarily have an issue with hyperparathyroidism. Lots of people develop kidney stones without having any issues with their thyroid, with their parathyroid gland. Most cases of kidney stones occur when individuals don't stay hydrated and allow the calcium salts to accumulate in their kidneys. So, okay, on that cheery note, let's move on and talk about the adrenal glands. The adrenal glands are pyramid-shaped structures that sit on top of the kidneys. They are not connected to the kidneys. It's just a convenient place to put them. The adrenal glands have two layers. We have a cortex and a medulla. Within the cortex, we have three sublayers and produce three distinct types of hormones in there. And the medulla, the inner part of the adrenal gland, is a link between the sympathetic nervous system and the endocrine system, because the medulla releases epinephrine and norepinephrine. Part of our whole fight or flight response results from the epinephrine being released at the medulla. We go into a scary situation, we are agitated, we are involved in some sort of an accident or trauma or something that triggers fight or flight. And so the hypothalamus tells the adrenal medulla, release the epinephrine. And that's where it comes from. So separate and distinct from the adrenal cortex. Okay. The three layers in the adrenal cortex produce what are known as corticosteroids, because cortico for cortex. They are steroid-based hormones, which means that they can slide right into the cells very easily. They're all based off of cholesterol as far as their structure goes. We have three layers. The zona glomerulosa is the outermost layer right underneath the capsule covering of the adrenal gland. The zona glomerulosa produces the mineralocorticoids. The number one hormone is aldosterone. You're going to hear about aldosterone again and again throughout this semester. It is probably the most important of the three corticosteroids. So we have aldosterone. The middle layer of the cortex is called the zona fasciculata, and it produces the glucocorticoids, cortisol, cortisone. You've heard of these. Hydrocortisone. This is the zona fasciculata. The mineralocorticoids regulate fluid levels. The glucocorticoids regulate glucose levels. And then the zona reticularis, the innermost layer of the cortex, is produce what are known as the gonatocorticoids, the sex hormones. The male and female sex hormones mostly releasing androgens, which are essentially testosterone. Now, these androgens will be converted to estrogen in the female. Okay, so here's the structure. So I showed you this in lab last week. We were looking at the adrenal gland. We have the outer covering is called the capsule. If an organ has a cortex and a medulla, it's going to have a capsule also. We'll see this again with the kidneys. We'll see it with the, not the pancreas, but the spleen. We'll see it with the lymph nodes. they're going to have a cortex and a medulla. They'll have a capsule. Directly under the capsule is the zona glomerulosa. The next layer down, the zona fasciculata, and below that is the zona reticularis. On the slide here, they're pretty distinct. Reality is they're in some places they all look the same. I'll just be perfectly honest on that. And then underneath all that is the medulla. So the mineralocorticoids, the zona glomerulosa, what is going on here with aldosterone? Aldosterone is the most important of the mineralocorticoids. What it does is aldosterone regulates sodium and potassium in the extracellular fluid, meaning in the interstitial fluid, in the plasma, all the fluid, in the lymph, all the fluids outside the cells. It regulates sodium and potassium concentrations in the extracellular fluid. Sodium is the #1 electrolyte. Sodium regulates the concentration and the amount of extracellular fluid we have. It regulates, sodium regulates blood volume, blood pressure, and the presence of all the other ions. Sodium levels dictate water levels. High sodium concentrations mean low water. You remember osmosis. With osmosis, water moves across a membrane from high water to low water. That's the basic definition of osmosis. Water moves across a membrane from a region of high water to low water. High water means low solute. Solute's what's dissolved in solution. So high water means low solute. Low water means high solute. The concentrations are different. Water moves across the membrane from a region of high water or low solute to a region of lower water with high solute to reach equilibrium. So we talked about something from AP1. Now, so sodium is very, very important. If our body retains sodium, think about this, if our body retains sodium, our bodies will retain water. The more sodium that we retain, the more sodium we get from our diet, the more water we're going to take in. What happens when you eat something salty? You get thirsty. Yeah, thank you. You get thirsty. So you get thirsty. So what do? You drink something. You drink water. Ideally, because your salt levels have gone up, so you drink more water to bring it back down. Well, what happens to everything that you eat and drink? Where does it go? Eventually, yeah, eventually. But where does it go first? The red stuff. What's that called? Circulates through our arteries and veins. What's the red stuff called? Blood. Thank you, blood. Yeah. So everything we eat and drink goes into our blood. So if we're eating this salt and we're drinking all this water because we ate all the salt, our blood, all that water ends up in our blood. It raises our blood volume, increases the amount of blood we have in our vessels. Now, if our blood volume goes up, our heart has to work harder to pump that. The harder our heart has to work to pump that extra volume means our blood pressure goes up. So what do we tell our patients with hypertension, with high blood pressure, not to eat a lot of? Salt. Salt's, anything with essentially sodium, because the more sodium you take in, the more water you're going to take in. The more water you take in, the more you increase your blood volume, which means the heart has to work harder to pump that extra fluid around, which raises the blood pressure, which is why we try to control how much salt we eat anyway. So sodium is very, very important to us. Aldosterone helps to stimulate retention of sodium. and sodium. And now what about potassium? Potassium is also regulated to some extent by aldosterone. What does potassium do? Well, potassium, remember on cells, the number one ion on the outside of a cell is sodium. The number one ion inside a cell is potassium. When a cell becomes depolarized, like a muscle cell, remember depolarization? Yeah, just say yeah, make me feel better. Thank you. So sodium rushes into a cell. It depolarizes the charge. You know, if you're a muscle cell, your charge is minus 90 millivolts. You got lots of salt outside. Sodium comes rushing in, and potassium goes rushing out. And you change the charge in your membrane from minus 90 all the way up to plus 30. You've depolarized, and you can get a contraction. Okay. The amount of potassium that's present determines whether or not you're going to get a depolarization event, whether you're going to get an action potential. So sodium and potassium here have a lot to play. Sodium's number one. Potassium is just sort of over here in the side watching, but it still has a role to play. The most important of these mineralocorticoids is aldosterone. Aldosterone allows us to retain sodium. It tells, aldosterone essentially tells our kidneys to retain sodium. And when we retain sodium, we have to retain water. And if we retain water, our blood volume goes up, our heart has to work harder, and our blood pressure goes up. So the role of aldosterone is to regulate our sodium levels, and indirectly, it controls our potassium levels too. For every sodium that we recover, we have to kick out a potassium. So if our sodium levels go up, our potassium levels go down. Aldosterone is regulating all this. Now, how do we control aldosterone? Well, there are 4 ways we do this. The number one mechanism, the most important, is something called renin, angiotensinogen, aldosterone. And this is probably the driver between a lot of hypertension cases. The second thing that regulates our aldosterone levels is how much potassium do we have in our bodies. Because if our potassium levels are high, our sodium should be low. If our potassium levels are low, if our potassium's high, sodium should be low. If our potassium's low, sodium should be high. We also regulate the release of aldosterone with ACTH from the pituitary gland. And the fourth mechanism comes from the heart. The heart releases a hormone called ANP, atrial natriuretic peptide. That's why we call it ANP. And this helps to fight back against the rise in blood pressure. So, renin-angiotensin. Now, it sounds like aldosterone just, likes to get in the way and cause troubles. But what aldosterone, the primary mechanism driving aldosterone is renin-angiotensin aldosterone. If our blood pressure drops for any reason, and the kidneys are always monitoring our blood, always our blood pressure, because remember, our kidneys filter our blood 60 times a day. So all the blood's going through our kidneys. The kidneys know what's going on. So if our blood pressure drops, the kidneys, there are cells in our kidneys that release a protein known as renin. Renin finds a protein in our plasma floating around that's not been activated, but it's still floating around, called angiotensinogen. Angiotensinogen is converted to angiotensin 2. Angiotensin 2, essentially the activated version of angiotensinogen, stimulates the release of aldosterone because your blood pressure is down. Your blood pressure is low, so your kidney cells release renin. your kidneys detect the pressure's low. Their response is to release the renin. Renin stimulates the conversion of the floating plasma protein angiotensinogen into angiotensin II, which then stimulates the release of aldosterone from the zona glomerulosa. Why? Because aldosterone tells us to retain sodium, which retains water, which raises our blood volume, which raises our blood pressure. That's why it does it. So we raise our blood pressure. That's a good thing. If our blood pressure is low, we can raise our blood pressure. However, what if our blood pressure is normal and we still release aldosterone and we still get, retaining sodium? Okay. So renin-angiotensin aldosterone is the number one way that we control our blood pressure. Of the two key mechanisms we use to control blood pressure medication, there's two key approaches. We either prevent the aldosterone from being formed, or the end result is to prevent the aldosterone from being formed. The blood pressure medications can go after one of two things. We have what's known as an angiotensin conversion enzyme inhibitor. It's called an ACE inhibitor. So it prevents the angiotensinogen from being converted to angiotensin II, or we have what's known as an angiotensin releasing blocker. We can't make the angiotensin II. They do the same thing. They both stop the angiotensin II from being formed to release aldosterone. Aldosterone's the problem. Too much aldosterone will raise our blood pressure. So the way we treat hypertension is to give patients what we call an ACE or an ARB, an angiotensin converting enzyme inhibitor or an angiotensin releasing blocker. In both cases, we stop the production of aldosterone. Those are the two, very, very common approaches to controlling blood pressure. Why do we have to have two of them? Well, it turns out that most people can take an ACE, the angiotensin converting enzyme inhibitor, but about 30% of the population that take an ACE start developing a constant dry cough. So the ARB was developed for them. So the other 30% don't like a dry hacking cough all the time with their blood pressure medication, go on the ARB. It does the same, it has the same effect. We control blood pressure by controlling the release of aldosterone. Now, other ways. Potassium, plasma levels of potassium. If our potassium levels are high, we stimulate aldosterone production, because that will get rid of the excess potassium. Because for every sodium that aldosterone retains, we have to kick out of potassium in our kidneys. So we can regulate our potassium levels by increasing aldosterone. That's not a bad thing. ACTH, we get stressed, so we secrete adrenocorticotropic hormone from the pituitary gland, and we release a little aldosterone there. Now, how do we deal with excess aldosterone normally? Atrial natriuretic peptide, ANP, from the adrenal, from the atria of the heart. If our blood pressure goes up, the heart will detect it. I mean, who knows more about blood pressure than the heart? The atria are being stretched. The two receiving chambers are being stretched. They release ANP. And they will block the release of renin from the kidneys and aldosterone from the adrenal cortex so that our blood pressure goes down. So short-term fix, not a long-term fix. Because our blood pressure our blood pressure goes up and down all the time. Our blood pressure goes up and stays up a little bit, we'll start releasing ANP to bring it back down. you ran up 2 flights of stairs and your blood pressure stays up a little bit because you might release some ANP, you're not aware of it, to block the release of renin and block the release of aldosterone. And so we stop retaining sodium and our fluid, stop retaining water, and our blood volume drops and our blood pressure drops and everybody's happy. The problem is that our bodies tend to get used to the elevated blood pressure. Because blood pressure, hypertension is not something you wake up with one day and say, oh, I've got hypertension today. I didn't have it yesterday. It takes time. It takes years to see an increase in blood pressure. You may see a gradual, if you are prone to hypertension, you may see a gradual, and some people seem to be genetically predisposed. You may see a gradual increase in blood pressure every year as you go in for your routine exams. And at some point, your healthcare provider says, well, I think we're going to have to put you on something to bring that back down. And so you do. The heart does its job to block the renin and aldosterone, but after a while, it gets used to the higher levels and the higher levels. So instead of running at a nice, 118/75, in 5 years, you're running at 130/85. Now, you've been fighting, your heart's been fighting back, but you just get used to the higher levels. Your new normal changes every year. So you have to intervene with some sort of medication. So anyway, those are the 4 ways to stimulate the production of aldosterone. The number 1 mechanism is renin-angiotensin aldosterone. Okay. Aldosterone has its own problems. We can hypersecrete aldosterone. It's called aldosteronism. Clever name. So if we have a tumor on the adrenal gland, we can secrete more aldosterone. The end result, hypertension, swelling. Because if we're releasing more aldosterone, we're going to retain more sodium. We retain more sodium, we're going to retain more water, which raises our blood volume, which raises our blood pressure. So we're going to develop hypertension. We're also going to be developing edema. We're going to swell. Your patient will be puffy. They'll be retaining a lot of fluid because they're retaining a lot of sodium, because water follows salt. Think about it. You eat something salty, what do? You get thirsty, so you drink water. You drink some sort of fluid. You drink a lot of water because you're salty, and that water has to go somewhere. And so we retain that water because we're retaining salt. And if we can't keep it in our blood, we keep it in our interstitial fluid, because plasma and interstitial fluid and lymphatic fluid, they're all the same water. It just depends on where it is. Plasma leaks out. Capillaries and vessels are leaky. No matter what we think, they're not a solid tube in a vessel. Water leaks out as plasma. It moves into the spaces around the cells and becomes interstitial fluid. It's collected by the lymphatic vessels, a parallel circulatory system we have, run through the lymph nodes to check for pathogens, then brought back to the blood as plasma again. So it's a loop, same water. If we have too much water in our plasma, we're going to put that into the interstitial fluid in the spaces around the cells, and we're going to swell up. We're going to get puffy. And so because of too much sodium. The other side of this is the more sodium we retain, the less potassium we're going to have. The sodium and potassium stay in balance. But if we are retaining lots of sodium thanks to aldosterone, then we're going to kick out potassium. We can't have high sodium and high potassium. We're going to have one or the other. If we have high sodium, we have low potassium. If we don't have enough potassium, then we can't depolarize. Or if we depolarize a muscle cell or a nerve cell, it'll depolarize once and never reset itself, never repolarize. Nerve cells can't function. Muscle cells can't function. So your patient dies. Now, one of the more well-known conditions with aldosterone is Addison's disease. Addison's disease is caused by the hyposecretion of aldosterone. You're not producing enough aldosterone. So we see your patient with Addison's disease, hyposecreting aldosterone, will have weight loss. They'll have low glucose levels. They'll have low sodium levels. Why low sodium? Because there's no aldosterone there to tell the sodium to stay. Potassium goes up because if sodium levels, remember, if sodium levels go down, potassium levels go up. Your patient will be dehydrated. Why will they be dehydrated? Well, if there's no sodium to attract the water, because sodium always attracts water. Water always follows salt. Water follows the sodium. If the sodium levels are low, then the water levels are going to be low. And if the water levels are going to be low, the potassium levels are going to go up. We're going to be dehydrated. We are going to experience hypotension, meaning our blood pressure will be very low. You treat Addison's disease with hormone replacement therapy. The number one sign of Addison's disease is increased pigmentation of the skin. Number one sign of Addison, before you do any kind of chemical analysis, increased pigmentation of the skin, your patient will look like they just stepped out of a tanning booth after they've spent like 24 hours in the tanning booth. It is the loss of water, the loss of sodium that alters the pigmentation. And so they look very healthy, but they're not. So here we see what it looks like. You can see the changes in appearance. We have what we call it hyperpigmentation. Notice the hand on the left-hand side of the image is more pigmented than the one on the right. We have this hyperpigmentation. That is the number one overt symptom before you do any kind of chemical analysis. So Addison's disease, low aldosterone leads to low sodium. It causes weight loss, dehydration, low blood pressure. Your patient is tired. They have problems with their digestive system. And the number one overt symptom is hyperpigmentation, not to mention any kind of behavioral changes too that may occur. Now, something that goes along with this is that Addison's disease also triggers a drop in cortisol. Addison's disease doesn't just affect the glucocorticoid and the mineral corticoids, in the zona glomerulosa. It affects the glucocorticoids too. So when you're not producing enough aldosterone, your cortisol levels are going to drop too. And that means your glucose levels will drop. So your patient has lack of energy in here. That's where the fatigue comes from. Okay. Addison's disease, who gets it? Well, about 1 out of every 100,000 people get it. It's equally distributed among men and women. We measure cortisol levels, we measure aldosterone levels. Fatigue, weight loss, loss of appetite, very low blood pressure, desiring salt because you're not retaining much salt. Your blood glucose levels are very low because you're not producing enough cortisol. You have nausea and vomiting, and you lose your body hair. So, and again, the number one overt symptom of Addison's disease is hyperpigmentation. That's the giveaway. Now, they may have just come out, your patient may have just come out of a tanning booth. So who knows? But, it's that only takes one question to solve that. Okay. Now, so that is the number one hormone disorder that affects the glucocorticoids. Well, it affects the mineralocorticoids, and it also affects the glucocorticoids. Addison's disease. Now, there's another one here we'll get to in a second. The glucocorticoids, the zona fasciculata, the role of cortisol is to help maintain constant levels of glucose. And we thought insulin was the one that did that. Well, insulin does, but insulin's role is short-term. Insulin's role is to open up channels in the cell membranes to let glucose go into the cells so the cells don't get hungry. Because a hungry cell is an unpleasant cell. But our normal levels of glucose in our body, if you ever have blood work done and you do the full blood work and it comes back and says, well, your blood glucose level, your blood sugar level is running around 80 to 85, and anything under 100 is like really good. Well, what's keeping the blood glucose levels at a constant rate? Well, it is the cortisol. Insulin helps to take excess glucose and put it into the cells. That's what it does. You eat a donut, you eat an apple, you drink your Dr. Pepper. The sugars in your Dr. Pepper or in the donut or the apple or whatever you have raise your blood sugar levels above normal, and insulin brings it back down. That's what it does. Insulin comes out to open up the channels in your cells so that extra sugar is taken care of. Now, what about the rest of the time? That's where cortisol comes in. Cortisol is cortisol release is controlled by the pituitary gland when it releases ACTH, the adrenocorticotropic hormone. It is released depending on what we eat and our stress levels and our activity levels. We just want to keep a constant level of glucose in our blood. That's all we want to do. And if our glucose levels drop, then we're going to start breaking down the fats and the proteins. Gluconeogenesis. Remember gluconeogenesis, from AP1 when we talked about cellular respiration and glycolysis and all those ugly things, remember all that? Well, at least I got to the second week before I mentioned cellular respiration. Anyway, gluconeogenesis. We can break down fats and we can break down proteins and form glucose from them. Gluconeogenesis. If we need more glucose, cortisol can go after the fats and break them down. We see this a lot in pregnancy. Where the pregnant female has to provide glucose for herself and for the baby, because glucose does go across the placenta. Now, cortisol will bring our blood glucose levels back up to to what we want as normal. Because this is, again, like glycogen. Glycogen is like the counterpart to insulin, it's the antagonist. Glycogen will bring you a short-term fix. You forgot to eat something. You were so excited to come to class today. You just couldn't wait to get to class and hear about all this good stuff. Indulge me. Okay. And you just forgot to eat. Glucagon releases glycogen from your liver to make glucose. Again, it's a short-term fix. What cortisol does is tries to keep us at a steady state, at homeostasis, to keep us in balance. So we run about 90 milligrams per deciliter of glucose in our blood. And so we keep our blood glucose levels right where we want them to be. We keep our fatty acids and our proteins where we want them to be. We don't want to see a rise in fatty acid levels or protein levels unless we need to. The more cortisol we have, the more control we have here. We release these glucocorticoids. Here's where we get in trouble. The glucocorticoids stimulate glucose production under stress. When we're stressed, we're going to release more cortisol. We're going to stimulate more glucose levels. What happens when we start releasing more glucose? We have to eat more in response to that. Stress often is long-term stress is often accompanied by increased consumption. which leads to weight gain, which raises blood pressure and blood volume. And, stress often leads to weight gain and obesity, which then contributes more to more hypertension too. So long-term stress is never a good thing, because our response to long-term stress is to release more cortisol, which stimulates more glucose for us, so we can respond to the stress. And there's the flow chart. The more stress we have, the more our central nervous system responds from the hypothalamus, stimulating the production of ACTH, which tells us to make more cortisol, which stimulates more glucose production. Breakdown of fats, breakdown of proteins if necessary. And of course, if we break down fats and proteins, how do we replace that? We replace it in our diet. So we eat more because we're stressed. And lots of times it may not even be the glucose. We're just like, I'm stressed, I got to eat something. Many people, respond to stress that way. Okay, so here is the counterpart to Addison's disease. This is this is hypersecretion of cortisol. We're overproducing cortisol. It's called the Cushing's syndrome. It depresses the production of bone and cartilage. It has an anti-inflammatory effect. Our body has, our body loves inflammation. The inflammatory response is how we respond to an injury. If you have a cut or a scratch on you, I don't know if my dog, that's just about healed up. If you got a cut or a scratch on you, you may notice a little red area around it, and that's fine. The redness around a cut or a scratch is what we call the inflammatory response. We increase blood flow to the region, we bring in more oxygen, we bring more oxygen and glucose, we bring in more white cells, so we can kill any bacteria, and we can encourage growth, and by having food there and oxygen there for the cells to repair the damage, and that's all a good thing. So that's the inflammatory response. Yeah, it's painful, it's red, it's warm, but that goes away. And it might hurt because if we increase the blood flow, we got more plasma to deal with. We might be pressing against pain receptors. The inflammatory response on that kind of scale is good for us. But what hypersecretion of cortisol does is suppresses all that. So we don't respond to an injury. We don't increase blood flow to try and promote healing. So we have a lot of problems in healing up from injuries. We also, it also inhibits our immune system. Our immune system likes to send out lots of white cells to fight infection and kill things. That's what they do. T cells like to kill things. In fact, we're going to see when we talk about the immune system, there's a type of white cell called the natural killer cell. It kills viruses, it kills pathogens, it kills infected cells. That's what it does. If we are hypersecreting cortisol, we are going to see that we are hyperglycemic, meaning our blood glucose levels are going to be elevated. We're going to see a breakdown in muscle and bone, because we are attacking the protein in muscles to convert the cells to break down the muscle cells to make more glucose, because we're hypersecreting cortisol. What does cortisol do? It tells us to release a lot of glucose. So if we are hypersecreting, we go after protein, we break down the collagen fibers in bone, we break down the protein in our muscle cells, and so to convert them through gluconeogenesis into glucose. We retain water. We retain sodium. If we retain salt, then we retain water. If we retain water, we retain salt and water, our blood volume goes up, our blood pressure goes up, and we fill up the extra interstitial spaces with extra water, extra interstitial fluid, we have the edema, we have the swelling, we have the pain. That is Cushing's syndrome, hypersecretion of cortisol. Lots of, I'm going to show you some more effects here. Now, Addison's disease also ties in the mineralocorticoids. Addison's disease is, mostly aldosterone on its effect, but it does also affect cortisol. But here we are hyposecreting the aldosterone. So, okay. Cushing's disease. It's a rare condition. Addison's disease is like 1 out of every 100,000. Cushing's disease is much rarer. About 10 million people a year may develop Cushing's disease. Mostly females, usually driven by a tumor. Now, normally our cortisol that we release helps to maintain normal blood pressure for us. If our cortisol levels are low, our blood pressure is going to be low. What does cortisol do for us? Well, when we get into a fight or flight situation, now remember, fight or flight deals with the medulla and epinephrine. The medulla releases epinephrine. What does epinephrine do? Epinephrine tells us to release lots of glucose from the liver and from the cells. So we dump out a lot of glucose. We can't release that glucose unless we have cortisol. While epinephrine is saying release the glucose, we got to have the cortisol to do that. So we have to have the cortisol present. Remember what cortisol does. Cortisol regulates our normal background glucose levels. So here are the symptoms of Cushing's. We have a lot of weight gain. We have what we call a pendulous abdomen. The abdomen hangs down. There are stretch marks on the abdomen. There are stretch marks on the arms. There is what we call the buffalo hump. There's a hump that forms back here. It's accumulation of fat. That's like the number one characteristic. That and the stretch marks are going to give it away. We don't heal properly because we don't have an inflammatory response to promote healing. We retain fluids. We have a lot of edema in here. Usually caused by, a lot of Cushing's is often caused by a presence of a tumor on the pituitary gland. So here's what we see. Excessive cortisol, Cushing's is caused by hypersecretion of cortisol. So we retain water. The moon face. Lots of people that take steroid hormones for some sort of therapy, they get a round face. We call it a moon face. Well, here we're producing lots of extra cortisol. Note the stretch marks around the abdomen. That's how the abdomen is we call it pendulous. It hangs down, and see the stretch marks there. We may see a lot of extra body hair too. This is all caused by the extra cortisol. The excessive amounts of cortisol. You remember what cortisol is going to, let me go back and say it again. Okay. With hyperglycemia, with excess glucose in here, we're going to retain more water and we're going to retain more salt, which raises our blood pressure and also causes swelling. So we see that now here. Note the swelling, note the edema around the face too. A lot of that is retention of fluids. Other symptoms here. Again, we see an A, the round face. Look at the buffalo hump on the man at the top there. You know, a very large accumulation of fat. We call it a buffalo hump because buffaloes have a hump behind their head. If you've ever seen the buffalo out in the glades, you know what I'm talking about. But there's a hump behind her neck. The moon face, these stretch marks. Look at the stretch marks here. We see the stretch marks here in the abdomen and on the breast. I mean, we see a lot of stretching here, very pronounced red stretch marks. There's a smaller buffalo hump there. And our patients bruise very easily. So excessive release of cortisol is going to trigger this. Now, some people develop what's known as pseudo-Cushing's, where their response to a great deal of stress is to mimic some of these symptoms. But Cushing's is usually caused by some sort of tumor affecting the adrenal cortex or affecting the pituitary gland. So now, and of course, just a reminder that hyposecretion that hyposecretion of cortisol occurs during Addison's disease. So Addison's disease is primarily a mineralocorticoid, but because it triggers hyposecretion of cortisol, it's also a glucocorticoid condition. So those are the two that you would likely encounter. More than likely, you would ever encounter is Addison's disease. Okay, now the third layer of the cortex is the zona reticularis. This is the hormone layer. This is the sex hormone layer. Most of these are androgens, male sex hormones. In a male, the androgens are converted to testosterone. They're usually the trigger for the onset of puberty in both males and females. Now, the androgens in females are converted to estrogens by the ovaries. And what do? Well, they trigger the onset of puberty. They trigger the secondary sex characteristics, you know, breast enlargement, facial hair, pubic hair, you know, egg release, sperm production, things like that. Adult body stature. The androgens are the sex drive in females, the trigger for that. And they are also the source of estrogen in postmenopausal women, because once a woman goes through menopause, her ovaries shut down and don't produce estrogen anymore. So the androgens tend to be a smaller source of estrogen for them. It is the amount of androgens released in the postmenopausal female is not nearly as significant as what's released during puberty, or in the case of the female in her fertile years, from puberty to menopause. However, it will have an impact in postmenopause. What you find in your postmenopausal female is that their sex drive will often go up once their ovaries shut down and the androgens take over. Your female will show up in the office and start saying that there's something wrong with her because her sex drive is way up and she's past menopause. And then you explain to her that is a perfectly normal response based on the presence of these androgens. There's nothing wrong with her. So now, problems with this. Hypersecretion of the androgens. Hypersecretion of the androgens. Overproduction of the androgens. In males, it's not a big deal because males may, you'll always have that male patient who hits puberty earlier than most and achieves his adult body stature sooner than other males of his age range, and hits the secondary sex characteristics. It happens. You always they went through puberty earlier than most of their peer group. They may have been releasing androgens at a greater rate. Later in life, you're not going to be able to tell. Once your male patient that went through puberty earlier achieves adult stature, even if they are overproducing the androgens, you're not going to notice. They're not going to tell. Now, in the female, if they overproduce, then there are some very definite changes that can occur. The female can become masculinized in her physical appearance. She can develop facial hair, body hair. Instead of just the pubic hair around in the axillary region or around the pubis, she's going to have facial hair, chest hair, back hair. Her clitoris may enlarge and assume the shape of a small penis. And so here we see, a woman with excessive body hair, facial hair right there. We can have back hair. We can see hair in the breast. We can see significant facial hair there. It occurs. It's called hirsutism, simply because of the extra release of these androgens. Many females that have experienced this for years, they were thought that there was something significantly wrong with them. The old, what they would call the freak shows, in county fairs and circuses and stuff. The famous bearded lady, if you will, would end up there because they were too, thanks to society not knowing what was going on, they were too embarrassed or ashamed to be out in public. So they would be that's all they could do. We know a lot more now. We know what's causing all this. I read somewhere that there was even thought back in the Middle Ages that this is where the whole werewolf legend came from, because they'd have this facial hair. They weren't supposed to. So, well, we all know people are strange. So anyway, okay, let's stop here because I don't want to go into the medulla. I've got 5 minutes. I don't have time to do that. We'll just stop with facial hair. We'll pick up with this next on Wednesday. Lab this afternoon, we're looking at the human reproductive system, and I'll have all the models out for that. Is that all that? So, and that's all I've got. And I'll see you all in lab.